radiograph, you can't always look at your radiograph and go, boom, I know what's wrong. So you have to start reading the radiograph to say, this is what I can see. Because it's not, you're not always going to give you the answer right off the bat. So you got to learn how to read the radiograph. Once you read the radiograph, you can start to put the pieces together. And sometimes you go, I want a T-fast before I do anything else to this chest. If I don't know how to T-fast, then I need to send this to somebody who does. All good?
Can fluid accumulation and alone cause the trachea to be dorsally displaced? Probably have to be like really, really severe.
Probably really severe, but even with if fluid by itself will displace your lungs.
Okay.
So here you can see that even though there may be some slight displacement of the trachea, it's not hanging out next to the spinal column. So there has to be something other than fluid. That's why I say, is there mediastinal mass? Maybe this crew's got lymphoma and they're just big lymphoid structures sitting right here. And all of this is pleural effusion that's obscuring the cardiac silhouette.
Can you expand on the T-fasces?
We talk about fast scans or focused, I can't even remember the acronym. Focused assessment, sonographic, something. Yeah, I'll get back to you on that. But the T is for thorax. There's an A fast, which is the abdomen. What's today? Today, Wednesday, Thursday? You guys are gonna have to look up fast again. Figure it. For sonography, for trauma. Forgot the trauma part. All right, I got most of it. Look at this going on here.
How old?
I don't know, middle-aged dog.
Because it's nice seeing you.
All right, so what's this?
Is that contrast?
Okay, so radio opacity, if I had to give it an opacity. A mineral opacity. I wouldn't call this an alveolar pattern. No, I wouldn't call it that either.
Biliary.
So this is what it looks like if your patient has esophageal disease. You give them barium and they aspirate it. And that is a barium bronchogram, which you don't want to do. So when we talk about those potential complications, this is a potential complication. You've got to be aware of it. You've got to be prepared for it. You've got to make sure your clients are aware of it before you do it. And then you're like, oh, we thought this patient was just going to, have a nice esophagram. And then you were like, oh, crap, need aspirated. Question?
What happens to the lung after barium?
Nothing nice. Big inflammatory response, and your best bet is to lavage, and send it to some place that does ventilatory support so that while all those inflamed cells die and regenerate, that your patient can get enough oxygen to stay alive. That's worst case scenario. But you warn your owners, you say this is potential complications. So if you run into that worst case scenario, they go, okay, they told me. I even signed something that said this is a possibility. Worst case scenario, doesn't happen with everyone. I didn't even see that one. That one was one that somebody else brought in and said, hey, this was horrible. And they're like, oh yeah, that's horrible. They're like, how's the dog? Good. Yeah. Hey. The dog is going to have an overwhelming inflammatory response in the chest. You need the lungs for oxygen delivery. If they can't deliver oxygen, your patient's going to die. Okay, those are the ins and outs of it. All right. So if you get that patient that you go, you know what, this is beyond my capabilities, I can only do so much nursing care, got an oxygen cage, but I don't really have the ability to do nasal oxygen, maybe I need to punt this guy up the street. Things I'm gonna do, if my patient is blue, dyspneic, arterial blood gases, because I wanna see how well that oxygen is getting from the alveoli into the lung parenchyma, or I'm sorry, into the vasculature. I may do airway washes, so you can either do one down the ET tube, that's going to be a little less invasive. I like doing bronchoalveolar lavages, that's going to get me more of what's happening on a cellular level in the lower airways. I can do bronchoscopy and see what's happening. Am I seeing lower airway collapse? Am I seeing inflammation? Are there nodules or growths or something that is of concern? I can also do my airway wash using my bronchoscope. If I have something very large, I might be able to do a fine needle aspirate. So if I have a big consolidated lung lobe and I'm not sure if it's an aspiration pneumonia, I can either bronchoscope it and wash it that way, or I can use an ultrasound and stick a needle through the chest on the side and get an FNA. Maybe it's a solitary mass or a lymphoma. We can use fluoro, helps us to see movement, whether I have any airway collapse. CT is awesome. The downside is most of our patients are going to be under general anesthesia for CT. Now you can train animals to go through a CT while they're awake, but the only way I've really seen that is in research studies where they actually like put the animals in a little thing that they got accustomed to, and then they ran them through the machine a couple of times to get used to the noises, and then they actually ran the CT. So really that's still limited to research institutions. Our patients are going to have to be under general anesthesia, which means we're going to get some degree of airway collapse. If we can put these patients on a ventilator, then we can get optimal views because we can expand the chest flow. Ultrasound, again, if I have something focal that's solitary, can be helpful in me identifying it, and I can use my ultrasound to guide me in my aspirates. But in most cases, ultrasound is going to be unrewarding unless there's fluid or tissue that I can see in the chest. Lung biopsy, self-explanatory. Nuclear scintigraphy can give us an idea of air movement, so we can label some molecules and see how well those molecules are actually making their way into the blood. That's going to be very advanced. We don't usually do that diagnostically, but there's a modality for that. So with arterial blood gas, it's self-explanatory. We want an arterial stick because we need to know what's in the arteries, how much oxygen is there. I can't test the oxygenation of blood from a venous stick because it's already gone through and delivered the oxygen to the cells, and all I'm getting is deoxygenated blood on the other side. So there is some technical know-how to performing this test. You got to have, the right syringes. You got to be able to, if you don't have pre-heparinized syringes, you got to know how to heparinize your syringes, stick your spot, and then you're running your test immediately. This isn't something I can send out to a lab. So I got to be able to run my blood gases on a machine immediately. So whether you have an iStat in your hospital or a vet stat with your IDEX equipment, it's got to be something that's run bedside. In your articles that are posted, there should be something about doing a BAL. This is something that you can do in general practice if you're comfortable with it. It makes some people nervous because essentially you're drowning your patient in order to get a sample from their airway, but we do it in a controlled fashion. So we make sure our patient is intubated. We put them under general anesthesia or at least a heavy sedation. We have a catheter. I like using red rubbers because it keeps me from perforating anything. And we have some saline that we're going to flush down the airway. We're going to pat our patient and have somebody sucking that fluid back. and then I can send that off for cytology and culture. So probably not something you want to do that you've never seen or done before by yourself, but if you've done it with somebody a couple of times, it gets easier. I like doing them because, one, my patient is intubated. So no matter how much fluid I flush down there, I can control their breathing. So after we flushed, we sit there and keep our patients on oxygen, and we do some positive pressure ventilation. The lungs are a perfect environment to suck up saline, because it's all just surface area. So when the pulmonary crackles go away after we've done this, and we breathe for our patient for a while, and their pulse ox comes back up to a normal level, that tells me, okay, we're done, and I can wake my patient up. So it can be done. Don't be afraid of airway washes. Most of the things that we do for our patients, therapeutic. Give them antitussives, and we start low end and work our way up. So we want to try the over-the-counter therapies. We talk to the owners about whether they need humidification in their household, or they may actually need dehumidification if there's mold or something within the carpeting or anything like that. If owners are willing to, I've had some owners actually remodel and pull up carpeting and do those things so that their pets can have a less moldy environment, get rid of dust mites in their household. Oftentimes in your clinical history, if the owners report that they've been doing remodeling and the pet's been in the household and they've suddenly started coughing, it's because they started breaking stuff down, and all of a sudden these microparticles were in the air. So getting HEPA filters can help with some of these patients, especially if they have an allergic bronchitis. Bronchodilators can be helpful, but be mindful that bronchodilators are really for short-term therapy. It's to help relax the bronchioles and allow them to open up so that air can get down to the lower airway and they're not trapping air in the alveoli. So this should be, for asthmatics, we talk about this as a rescue therapy. So you pull out your rescue inhaler, open up your airways, but we need to make sure that we're managing whatever that primary condition is with appropriate therapy. So that might include steroids. Copage can help. You guys know copage? That's where you pat them on the side. You do it to your dog every day when you get home. You're like, hey buddy. That's copage. You pat them on the chest. We're going to do it for a medical reason. That's if our patients have bronchopneumonia and they're coughing up crud. We're patting them on the side to help them break up those secretions so that they'll come up with that mucociliary apparatus and they can either swallow it or spit it out. Now the oxygen cage, all practices should have them, but you need to understand the limitations. You get that asthmatic cat that's like, throw the cat in the oxygen cage and no touching. Go work out whatever calculations you need to work out so that you can give that cat some drugs. Pop your drugs in your cat, put it back in the oxygen cage. What's bad about this is when you need to really do something to that patient, once you pull them out of the oxygen cage, it's gone. So we can do things like flow-by, give them some sedation. If they're struggling to breathe, a touch of Torb goes a long way. Just a little bit of Torb so they're like, okay, I'm not freaking out. I've actually seen pink elephants. That kind of freaks me out, but I can breathe better. Put some little flow-by oxygen in front of their nose, not shoved in their face. You shove it in their face, they're like, struggling to die. So we don't want that. We don't want to struggle to get blood from this crew. Struggle, 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 die. We don't want to struggle to get radiographs. Struggle, 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 die. So a lot of it is, what can I control immediately? So if I have an asthmatic cat, he's getting a shot of steroids and a shot of a bronchodilator. But you might not get that at the same time, because it's like, okay, put the cat in the oxygen cage, I'm going to get some steroids. Okay, pull the cat out, here's your steroids, put the cat back in the oxygen. Let the steroids take effect. Somebody stand there and just watch the cat breathe. Don't touch it. And you kind of do this back and forth type of thing until you get your patient stabilized. Once he's stable, yeah, then I can place an IV catheter, and then I can go take some radiographs. But I want to go, hey, I think he's asthmatic. Oh, he's breathing kind of tough. Let's go take some x-rays right now. And that's the fastest way to a dead cat. So understand the limitations of the oxygen cage. Nasal oxygen actually helps you to take your patient to do things. So if my patient is oxygen dependent, if I can cart the oxygen with my patient, then I can take him to radiology, he's still getting oxygen, and I can get the study that I need, instead of, let me pull him out real quick and see if I can get this done, and crap, he's struggling, and I didn't get any good films, and now I gotta throw him back in oxygen. So, just understand the limitations of your oxygen each. So, nasal oxygen is great, we can do nebulized therapy, so if our patients have a lower respiratory infection that maybe our antibiotics aren't really covering very well, we can nebulize some medications, we can just provide more humidification down in the lower airways, we can nebulize bronchodilators, so nebulization therapy can be very helpful for our patients both in hospital, and if the owners are willing to do that at home, we can teach them how to do that at home as well. Some of our patients are going to need chest tubes. So ideally, we want our chest tube in a good place, so whether they have a pneumothorax or a pleural effusion, if I tap that patient 3 times and they're still building up a lot of effusion or they're building up a lot of air, then that's going to be my criteria for you get a chest tube. You know, if I'm having to repeatedly perform thoracocentesis to keep that patient comfortable, you're getting a chest tube. Some of our patients, I mentioned the one with the barium, that was a prime candidate for ventilatory therapy. Now, ventilatory therapy means the patient is kept in an anesthetized state. They have a nurse that is sitting next to them 24 hours a day. You see, we have an apparatus set up. This is the ventilator, so this machine is breathing for them. We can't keep them on 100% oxygen forever. 100% oxygen is toxic after about 24 hours. So we have to balance the amount of oxygen and room air that these patients are getting. So they're getting just enough oxygen that it's not toxic to the cells in the airway, and enough additional air so that we're actually filling their lungs. And if we can buy them time and let the lungs heal on their own, then we can discontinue our anesthesia. You see this guy's got a propofol drip going in order to get that patient off the ventilator. Unfortunately for our patients, we tend to put them on the ventilator too late because we piddle with them. We go, well, let's try this and let's try that. And he's been cyanotic for a while. He needs to go on the ventilator. By the time we get them to the place that says, yeah, he needs to go on the ventilator like 3 days ago. If he went on the ventilator 3 days ago, he might have recovered. But right now, our stats aren't very good about getting these guys off of the ventilator successfully because we didn't give them enough. We didn't start soon enough, and we didn't give the lungs a chance to heal. So, and it's expensive. We had a nurse there 24 hours, working with criticalists 24 hours. This is going to be probably, $5, $10, $30,000 later, and they may not have a dog, so. What was that?
Well, I used to work with 2,500 a day.
So $2,500 a day, just to sit on the ventilator and hope your dog makes it.
They got some real cute shelters down there.